Good morning, everyone, and welcome back to our second day of education on clinical considerations of substance abuse and critical components of proper prescribing. I hope that you found yesterday's sessions to be informative, and I know that you'll hear a lot of great information today. These sessions have been developed in partnership with the Kentucky Board of Medical Licensure, and we also gratefully acknowledge the unrestricted educational grant from the Federation of State Medical Boards Foundation in the amount of $10,000 to support this educational effort. For those of you that don't know me, my name is Dr. Brent Wright, and later today I will become the immediate past president of the Kentucky Medical Association.
It's time to raise your guard, Kentucky. Immunizations protect your kids and your community, and right now that protection is more important than ever. Learn more at raiseyourguardky.org, paid for by the Kentucky Medical Association, the Foundation for a Healthy Kentucky, and Anthem Blue Cross and Blue Shield in Kentucky.
That's just a quick preview to the video you'll see later. The incoming president, Dr. Dale Toney, will focus on the health and well-being of both patients and physicians across the state. He will be promoting the KMA and the Kentucky Foundation for Medical Care's Be Well, Stay Well initiative, which encourages Kentuckians to take the right steps to improve their health during this time of uncertainty as we navigate the COVID-19 pandemic. We've already begun this work through the successful Raise Your Guard KY campaign, which launched last week and emphasizes the importance of maintaining well visits with your physician and making sure your scheduled vaccinations are up to date. Here is a short clip of our video.
It's time to raise your guard, Kentucky. Immunizations protect your kids and your community, and right now that protection is more important than ever. Learn more at raiseyourguardky.org, paid for by the Kentucky Medical Association, the Foundation for a Healthy Kentucky, and Anthem Blue Cross and Blue Shield in Kentucky.
I hope you will join Dr. Toney and the KMA by supporting this and other efforts through the Be Well, Stay Well campaign this year. Today, we will continue to learn about different facets of substance abuse, including how to recognize symptoms of addiction, an update on CASPR and reporting information, and in just a moment, we will look to the future and hear about some of the implications of substance abuse on our communities and patients. As a reminder, please complete the SurveyMonkey evaluation that will be emailed to you in order to claim CME credit. We also encourage you to ask questions through the use of the chat function. We will answer questions at the end of our presentations. Our keynote speaker this morning is Dr. Rahul Gupta, the Senior Vice President and Chief Medical and Health Officer at March of Dimes, the nation's leader in maternal infant health. In this role, Dr. Gupta provides strategic oversight for March of Dimes' medical and public health efforts to improve the health of all moms and babies. Prior to joining the March of Dimes, Dr. Gupta served as West Virginia's health commissioner for 2 governors. As the chief health officer, he led the state's opioid crisis response efforts and launched a number of pioneering public health initiatives that have been recognized nationally and globally. We are honored to have him with us today, and with that, I'll turn things over to you. Dr. Gupta?
Thank you, Dr. Wright. Really appreciate the invitation, and it's an honor to be here speaking to all my peer colleagues. Thank you for having me. We're gonna start today, and as we do, I'll put my presentation on. Thank you for joining me today on this to talk about a look into the future. It's very important in so many ways to not only discuss the clinical community aspects of it, but also economic implications of substance use. I think we're gonna find out as we discuss today how this is another aspect of the pandemic that may be impacted and is important for your practice. So I want to talk about a little bit about just often we talk about in various versions of opioid crisis. I want to talk about it as a very purely a supply and demand issue. Also, as I mentioned, what happens when a pandemic collides with an epidemic that already exists, and we'll share some data on that. And what can you expect in the future? I think it's very important for us as physician leaders in our communities to really understand that and be prepared for it, because it is an evolving crisis. Let me start first by talking about the opioid epidemic as a supply and demand issue, because it is one. this is the information that I want to share first and foremost about life expectancy in United States as well as in the other Western comparable countries. What you'll see here in this chart is basically that compared to the average of other comparable countries, all the way from 1980 to about 2017, we've had a flattening around 2014, and then we had a direction going down. I think that's, unfortunately, it was the first time in modern history that we've seen such a trend. It's a disturbing trend, and it's not just substance use, but it has a number of other underlying community factors that we'll discuss today that actually result in this type of trend. And it is one, if you combine that with, we have some of the lowest fertility in the last 3 decades in our country, and an increase in deaths and life expectancy lowering, as well as the pandemic. I think we're setting us up ourselves as a nation to be in some peril in the future if you don't recognize it correctly. So the next slide I want to talk about is, if you look at the years particularly, you'll see the total and male to female life expectancy in the United States. So you can see basically in 2016, 15, we're toying around about 78 or so years, 78.7. So we're not in grave trouble, but there's an opportunity here to recognize our challenges. This is just a map, heat map that was done by New York Times, that shows us the progression of the opioid epidemic and drug overdose deaths. But you could see all the way from 1999 how, our area, mostly in the tri-state area of Kentucky, West Virginia, and Ohio, were pretty much impacted at the time. And it has, we were somewhat the canary in the coal mine, so to speak. And this has now spread across the country. But there is an evolution that is occurring right in front of us. And I want us to recognize that, because this is a chart that shows all the way from 1999 for about 20 years afterwards to 2018, what are the causes of deaths from overdose that involve opioids. And one of the things it'll be striking to you to see is actually any of the opioid overdose deaths actually have flattened out. Although last year, I'll talk about separately, because this chart goes only until 2018, was a surprise to us, and it set up a record. However, and I'll talk about why that we predicted that. But the real important piece here to notice is, if you look at the purple line, which is the commonly prescribed opioids, that actually is consistently and reliably going down. Meaning we as a country, as you as physicians are doing a great job. We have actually rose up to the challenge to address this problem. Yet, there are other troubles that are lurking around, which includes not just heroin, but also what we call other synthetic opioids. So there's a number of synthetic opioids that we use. For example, methadone is one of them. But if you remove methadone, this doesn't talk about methadone, but you talk about the street, most of these are street drugs like fentanyl and fentanyl analogs. We're seeing a lot of those. Clearly, one of the big ones is called isotoniazine, also called Tony on the streets. And it's being increasingly identified as cause of overdose. These are all, they're pressed as pills in sort of commercial pill pressers that drug dealers are able to get. They look like pills for all practical purposes, but they are built or developed and manufactured in clandestine labs. Some of them are coming from China and being converted from prodrug to the active drug and being transported through the highways, literally the veins and arteries or system of a nation. So this is going on right now, and it's important to recognize the evolving epidemic, which is, and I'll talk a little bit what these synthetic opioids and what other, I do have one slide to talk about, but the point is that the prescription drug job we're doing a good job of, but yet the overdoses are continuing. This gives you an idea of the states that have the highest per capita overdose deaths in the country in 2018. So I've listed these out on the side. You can see West Virginia remains one of the highest ones, as well as Ohio in our area. But you can see Kentucky is about number 9. And it's important because I mentioned the highways, that's how the drugs are traveling. So the contiguous states it's important to note that what happens in the next state does matter, just like what happens in the next county that you're practicing in, no matter where you are, it does matter. So this is an issue that is important. This is a little dated graph, but it still holds, which is from 2015, that shows where are the most folks dying, what age. And that's the unfortunate part in our country right now. If we had an epidemic that was killing off in substance use, a particular age of people, you have to look at that. And for this one, it's usually, and it's mostly between the ages of 25 and 55. Why that's important? Because that goes back to the labor force participation, economics of a community, economics of the state, and certainly of the nation. So what it's also doing is kind of like double hit. On one end, we're seeing the death of people and suffering of many more. On the other hand, those people that are dying and suffering are the ones that are being excluded from the workforce. And I'm going to talk about that a little bit, why it's so important to note that. This is a slide that really shows us the, remember we showed the map for up to 2018. Now here's some predictive analytics. So this slide shows us the predicted overdose mortality rates from January of 2019 to January of 2020, fresh, new information. What we're seeing is, so last year, literally, this country set a new record for overdose deaths, about 72,000, a new record. We went up about 6.6% overall for the United States. So I pulled up the Kentucky data, and we've done better in Kentucky than the rest of the country, but still we've gone up by about 2.5%. So it's still the deaths, we're talking about mostly overdose mortality, and it was going up. So of course, you can see across other areas of the country that other than Dakotas, there's many others, and some of them had drops, mostly in the Midwest and the West. So this is just what's most current information. Now let's talk about the supply side drivers, because we've talked about the issue. Now what drives it? So as I mentioned to you, this is a graph that looks at the high dose, the more than 90 milliequivalents of morphine. So MME, that's the morphine equivalents, and between 2006 and 2018. So what you're seeing here is a consistent decline, both in temporal trends overall, as well as in the high doses at the bottom green line. So we're seeing consistent declines. The CDC recommendations, the stewardship in opioid prescribing, that our boards and community legislation, as well as, of course, the physician leadership, has caused this to be. So we have become now a part of the solution, no doubt. And that's showing up in the data, and those numbers are declining. And as I mentioned, this deaths are still there, and we can talk about why that's the case. Now, this slide really looks at the rates of overall annual opioid prescriptions per 100 person rates, basically, per prescription. So what you're seeing is, if you start to look at less than 30 days, that has probably the sharpest fall. So we're talking about, for a toothache or for an ankle sprain for a 17-year-old kid that may have gotten a football ankle sprain. We've seen all of that, and some of that's because of now more and more states and jurisdictions are saying, no, you can't just do that. You got to have a reason to start opioids, and shouldn't be the first line. We're still seeing declines for both less than 7 days. That's also a major piece. That's the orange line here, and then you're also starting to see declines for more than 30 days. And then the less than 3 days or less than, and between 3 and 7 days, prescriptions have been a little less in decline slope, but it's still declining. And remember, it's the 3 to 5 days that really we see from studies that leads some people on the path to addiction. So it's important, not so much for less than 3 days, but really for the ones that are getting longer, more than 7 days, more than 30 days. So I think we're on a pretty good path for that. Now, let me share with you some Kentucky data. So obviously this data, I'm going to go back a little bit here, sorry. So this data comes right, from CASPR. This is your prescription drug monitoring program. and I pulled up the most recent data. That's from 2011 to all the way to second quarter of 2019. So of course, the quarter one, quarter two of 2019 is a fourth of the data. But if you look at for all prescribed scheduled prescriptions, you can see that there was a going down, and this is slight trending up at least until 2017 and 2018. But this is for all controlled substances. So let me break that down into what that looks in Kentucky for you. So if you're looking at this, the issues of gabapentin, which is obviously Neurontin, there's a large chunk, as well as the hydrocodone, which often is Lortab and Vicodin, and oxycodone, Oxycontin and Percocet. So those are the largest three pieces of the prescription as per Casper. We're also seeing, of course, the deadly cocktail, which is if you mix it with some of the diazepam group of drugs along with the opioids. We, of course, have a significant chunk of Lyrica, pregabalin, and then you're seeing all of the others. So this is what the prescription sort of spread looks out for the entire controlled substances according to Casper. I want to bring you back a little bit to the bigger problem I think we have. I certainly am one that believes that this is part of the problem. If you look at this slide, this looks on the left-hand side as of total number of prescriptions over time from 2014 to 2018 in the United States. And believe it or not, we prescribed almost 6 billion prescriptions that were dispensed in the United States in 2018. That up to 2.7%. So if you just keep focusing on the left hand of the slide, I mean, it's a whopping number. I did the math. That comes out to be about 19 prescriptions per person in the United States. Man, woman, child, infant, baby. Everybody, if you do it. And we know everybody doesn't get a prescription, and there's some who are getting 30 to 40 scripts written for them. And this includes veterans, it includes senior citizens, and everybody. But still, 19 prescriptions per patient, per resident in this country is a huge number. And that's part of the problem I think we're having to deal with in this country. Now, when you look on the right hand of the side of the chart here, you will see that the steepest drop, if you see in prescriptions, was down about 17% from 2017 levels. So within a year, we saw a significant drop in 2018 for opioids. So while we're seeing steep drops in opioid prescribing, we're seeing this divergence of increased overall prescriptions in medical practice, and that's somewhat troubling. This slide really talks about overall the state level opioid prescribing rates, and again, I just put this there to show you and impress you with 2006 on the left to 2018 on the right, that how much improvements we have made across the country. We, of course, in that same area are still struggling with Kentucky, Tennessee, and West Virginia to find to further lower rates. Then I want to hone in to the same map by county, and we're going to go back and hone further into this county area. Remember, we showed the New York Times map that showed that we had pretty much become red. So if you hone into this area, this is what it looks like. So you've got in 2006, Kentucky, West Virginia, Ohio, and Northeast Tennessee. And then you can see here by county, how many of those, the light red and the yellow means that they're much less prescribing, and dark red means that there's a much more prescribing. I'll share some of those Casper data with you in a second, but just want to show you here that it is a regional problem, and it does cross state borders, state lines and county lines. So the prescribing as well as the overdoses don't respect state or county lines, bottom line. Now, if we look at that Casper data for second quarter of 2020, you'll see the areas by the patient's address where people are receiving more than 90 milliequivalents, morphine milliequivalents, basically. And you can see there's a few dark counties here that the rate is really, really high. And those are obviously going to be the focus of both regulators as well as others to look at. But then you look at the overall by patient address, all controlled substance users on the left, and the combination of opioid and benzos, the 7-day overlap on the right. And you can see, because that's really what leads a lot more to overdose and deaths, the combination of depressing the respiratory systems, both with benzos and opioids together. And you can see on the right-hand especially, there are some of the very similar counties that have also the higher morphine equivalent doses, the more than 90 MME doses. There's very much the same counties here that are also having somewhat more prescription of combo between opioids and benzos. And it's important to note that, because those are the people who are going to get in trouble. Those are the patients who are going to actually end up either overdosing, whether it's fatal or non-fatal, but ultimately it will become fatal. So it's important to capture that to begin with. But there's certainly areas, I guess it's important to note, within the state that are much higher risk for people to be on the risk for overdose. So I promised you we'll go back to this map, and this is the map that actually shows what's happening across the country. These are the age-adjusted rates per 100,000 population drug overdose deaths. And what you can see here is, once again, the prescription opioids pretty much flattening or going down in the recent years, but synthetic opioids, other than methadone, look at the line, this blue line, that the deep blue line. This is actually the solid line. This is going straight up. So as opposed to heroin or cocaine, and there are these stimulants in play, and I'll talk about that a little bit. The stimulants are really a challenge these days, because now we used to have people who would either take depressants or stimulants. Now we have cocktails on the streets that people are taking that have both. But it's the synthetic opioids that are becoming easier to manufacture in clandestine labs, even being shipped, as I mentioned, from other countries, coming to the ports, and then they're the ones that are creating havoc in the community. But it's not that it's just people who are addicted, it's reasons why they're addicted that leads to the feeding of the problem that we will talk about a little bit. But this is, I want you to keep focus on the synthetic opioids, not necessarily always the ones that are being prescribed in doctors' offices. That's becoming a bigger challenge these days, and that's the part of the evolution of this epidemic. It began clearly because the volume of opioids that was out there, but now it's now transitioned off and evolved into this synthetic opioid problem. This is coming out from HIDA, the high intensity drug trafficking area. You may have some of the HIDA offices in your community, or maybe not. But this report really talked about some of these factors. And from 2017, this is a combination of the Drug Czar's office, DEA, your local law enforcement, and federal law enforcement working together. And what they found in the seizures is, you can see in 2017, 83% was either cocaine and crack, basically, and then 14% was meth and ice. So even the seizures are changing, and there's some fentanyl, and you don't need a lot of fentanyl, of course, to cause problems. But then there's heroin. So this is what the seizures look like. So I want to show you the little comparisons between heroin seizures from HIDA across the country, but especially in our area, and coke and meth seizures. So you can see both slides, left and right. And of course, the pink, it's the percentage in kilograms. So obviously, the dark red means bad news, and the pink is getting to bad news, basically. But you can still see, I mean, to the point I'm attempting to make, anywhere across the country, you see it is not a state problem. Oftentimes, it's a border problem, meaning it's across the state borders if it's happening. So you can see that all over on the west. You can see it certainly in the northeast. But then if you look at our area here, you can see how the trafficking is concentrated. And it's usually often along interstate routes, along southern West Virginia, Eastern Kentucky, especially southeastern Kentucky, and northeast Tennessee. So this is the piece. And it's very much remarkably similar to in higher volumes, meaning many more kilograms, but it's higher volume for coke and meth, but it's the same type of pattern. It's striking how the patterns for drug dealers and drug trafficking are very much similar. And these are some of the largest drug interdiction and seizures that I think we have to be aware of that are happening across country. I mean, everything from the Coast Guard, seized, in ships to the nearly 254 pounds that was fentanyl that was seized in Jackson County, West Virginia. So you can imagine how much of this, Jackson County is a very small county in population size, I can tell you. There's not much going on there. Yet you could see to have 254 pounds of fentanyl, worth, that many millions of dollars. It's just a matter of time before it was going to go and be distributed and kill people. I mean, this was enough to kill a football stadium full of people or more. So now let's talk about, because we often have focus on supply side, and certainly, indeed, we need to, but it's important for us to also focus on the demand side. What is driving the demand? And I think there's a pretty good consensus that these are the factors that are driving the demand. We could spend a lot of time on each one, but I want to mention that these are important factors. So community and economic disadvantage is really an important factor. And I will bring this to your attention now because the tens of millions of job losses that you're seeing, these are your patients coming to your offices as a result. This will and has the potential to worsen the opioid crisis or the drug overdose crisis. We have seen a relation where folks have done the studies between the counties that have job losses with higher rates of opioid consumption as well as overdose. So that matters a lot at a local level when we're seeing our patients. The second piece is mental health and lack of community addiction resources. So Kentucky has done a great job over the years to increase the capacity for community level resources, as well as beginning to address mental health problem in people who have addiction is not the exception, but the rule. It happens oftentimes, and it allows treating addiction allows people then to have opportunity to treat their mental health and really get back on track. Relational problems, obviously the loneliness, the social media rather than actually community and individual connections and family, it is both a cause as well as a result of addiction. And of course, one of the things we've seen in the reason that particular area of the country is more impacted, and especially when we look at Kentucky, Tennessee, West Virginia, Ohio, is because people have been working in jobs and industry like mining and steel and manufacturing, which are pretty tough places to work at, and they end up having individuals that require chronic pain management, as well as increasing obesity and other factors. So as I mentioned to you, the supply side, on the demand side, clearly the fentanyl is on the rise. We are seeing, of course, people who use heroin, people who are addicted to alcohol, for example, are 2 times as more likely to be addicted to heroin, and marijuana, they're 3 times as more likely to be addicted to heroin. Same thing with cocaine and painkillers. So we know this data. It's important that one substance is as bad as the other in so many ways. I want to share some of this data from OSU sort of faculty, Mike Betts. And, what he did was he looked at, our region. So he looked at the industry and jobs in Ohio, West Virginia, Kentucky, and Pennsylvania. And the point of this is the following. He looked at in 1992 on the left-hand side, the 2 pie charts, and compared that with 2016, the proportion of people who had less than high school education, all the way from high school to 2-year to bachelor's. And you can see what's happened from 1992 to 2016, that there has been a lot more people. If you basically see is, you can see that there's a lot, high school graduates have gone down basically. The challenge is this: if you look at the right-hand side in Ohio's industries, from 2000 to 2015, manufacturing has gone down. You could look at maybe retail trade a little bit, but healthcare and food services kind of have gone up. Well, what could go wrong with that? What goes wrong with that is this. A lot of the less skilled people who were high school or less graduates actually are the ones who have lost their jobs through manufacturing. But for healthcare, as we know, you need a lot more expertise. We need at least a college degree. So what's happening is this: we may have a very low unemployment rate prior to COVID especially, but a lot of these people with high school or less have gone out of the market. And they're the same people who have loneliness, they have issues with pain, and they're the ones who are feeling hopeless and falling and succumbing to both either prescription or street drugs. It's important to note that because there's 3 million restaurant workers today that could be subject to automation. There are 3 million cab drivers, for example. When you have automated cabs, they'll lose their jobs. Same way with trucking industry. There are millions and millions of jobs at risk today, not because of anybody's fault, but because of automation and artificial intelligence that could be lost to better technology, give it. But at the end of the day, these are people that are going to come into your office. They're going to have, hopelessness. They're going to have issues of mental health that, if we don't address, will end up in much negative consequences in terms of addiction and overdose deaths. So this is the regional data I want to share with you. The U.S. manufacturing data on the left, and you can see all the way the U.S. manufacturing from 1967 that went down in terms of the amount of jobs all the way to 2007, 2010, and then started to rise a little bit. But if you look at that and compare that with the particular jobs in our region, Kentucky, Ohio, Pennsylvania, and West Virginia, you could see, the amount of jobs that have over 1990, every 2 years, we're monitoring those, that have literally have stayed steady, but they're rising a little bit, but that's not matching now, because if you can, the point is that when they go down, that as they did in 2008 and 10, that's when we have to address the local economics, and that's when it becomes important. So just to, at the point in 2016, there was almost 2 million people with opioid use disorder. Those 2 million people could account for 78% of the non-boomer labor force participation drop. So what that means is, of all the people that had opioid use disorder in 2016, you can literally explain 78% of them because they stopped working. And that number, at least Mike Betts believes, could be about 100%. 100% in Kentucky, Ohio, Pennsylvania, and West Virginia. So literally saying, developing this one-to-one correlation between job loss and the risk of having opioid use disorder. It's a very important piece that we've got to know, to be aware of. So what happens when a pandemic collides with an epidemic? There are some recent reports coming out just now. These submissions were from January to March compared, and then compared to March to May. And what we're seeing is that we're seeing about 18% increase in suspected overdose submissions. So we think there's a lot more spike alerts across the nation that are happening like this, but ODMAP is it comes out of HIDA participation. Basically every time a firefighter or sheriff's department or somebody goes to response, they can put it in the app that we've seen in overdose, and it tracks that. It has some other functions too, but one of the things that they're highlighting right now is we are seeing a rise in overdoses. That means we're going to see a rise in overdose deaths. And that means that, we broke a record last year. We may have, unfortunately, much more this year. And that's important to know because, and there's a lot of reasons for it. A lot of the treatment centers are shut down. A lot of the counseling services are shut down. People are having more difficulty getting out to begin with, but also the isolation is increasing for people. So, when we're doing virtual care, it's very hard to have that one-to-one contact and be able to avoid each time, we are considering a prescription opioid, for example. We're seeing clearly a worsening opioid crisis. We're seeing a number of reports that are coming out. Just wanted to bring attention to that, and then high rates of also stimulant and other synthetic opioid uses. So what can we expect? A colleague, Don Burke, who's formerly the Dean of School of Public Health at Pitt, basically did this forecast way back in 2017. And he argued that we could see a forecast of continuing rise because of all the factors, and at least part of that factors that I mentioned today. There's also a simulation done that shows that, all the way up to 2020, and we're clearly seeing that, and we can see an increase. And I think that's important to note that there are factors beyond control in some ways, like automation, artificial intelligence, but also the pandemic that could make things much worse, as well as the drug dealers and the importance of working both the public health authority, regulatory authorities, physicians with law enforcement has never been more important, because this is not exclusively a prescription drug issue at this point. Kentucky's made a lot of progress, I could tell you, whether it's having naloxone availability, training of professionals and laypersons in naloxone, Good Samaritan and prescribing laws. Obviously CASPR is a great job, expansion MAT. Harm Reduction Coalition in Kentucky that is now allowed to develop such programs at community level with the ability of the local folks to have an influence on it. And we still need to continue to have surveillance as well as drug diversion and control, which I think it's going to have to be a combination in order to achieve the benefits. And as I, happy to take questions from you, and I really encourage, if you all have any thoughts or questions, please, ask us or put them in the chat box. I just want to share this, White Matters. I mean, White Matters every single day. But I became a part of this group on the board of this SAFE project, and what basically got me interested in this is at the time, the guy that you see in the white t-shirt here, was the vice chairman of the Joint Chiefs of Staff, and you see Jonathan, their son, and Mary on the right. A loving mother, great people, educated, every aspect of every, we can imagine resources available. Yet, and Jonathan, what I understand, really bright kid, just what you look for in the future generation in this country. And, after struggling with addiction, challenged to find the appropriate evidence-based ways to get treatment, overdosed. First year in Denver, in college, in his dorm room, and died. And so his parents have started this called the SAFE Project, and it allows us to, they're working to, we're helping to have safe campuses across, safe communities, veterans, and the idea is to have, look at both from a law enforcement, but prescribing, talking to people, looking at the future generations. The 6 pillars really talk about the importance of a concerted effort, which is not in isolation. So I think part of our sort of charge in medicine is to start looking beyond the 4 walls and thinking about what it's going to take in my community to address this problem, because this problem tends to be, as I mentioned, hidden, and the best of us have suffered through this. And we've all of have seen that happen in our communities. I will just mention this as we close, this part, that it's really a syndemic. What that means is the opioid epidemic is an epidemic of epidemics. where not only it's not an issue of how do you do it, but when the pain clinics get shut down, people that are almost also legitimate pain patients also end up going to ER or going to on the streets to get medications. It's a challenge. We've seen the outbreak of communicable diseases. Really, the largest outbreak of HIV happened a year or two ago in West Virginia, Huntington, right next to the Scott County in terms of numbers for HIV. We're seeing clearly, so many other things happen as a result of this that I think it's an important piece that we have to, it's rarely that you see one cause so many different other problems, and this is one of those that we have to be on the watch for. The bottom line is that the drug crisis really began as a supply problem, but it continues to evolve as the demand increases now. This is as I mentioned, epidemic of epidemics, where a significant impact from COVID-19 can be expected to happen. The societal costs overall may be very significant and because the local economic conditions and job losses not only influence, they're the cause, oftentimes a result actually from the pandemic, but they will definitely influence overdoses and deaths for this epidemic. And I think it's important for us to be aware of that. And most concerning is that the coming automation and artificial intelligence will likely exacerbate the drug crisis. Not that that's a bad thing, but we need to be thinking ahead and planning for it. Because if people lose their jobs, this hopelessness is part of the problem that happens. With that, I'm going to go ahead and here's my contact information. It's rgupta@marchofdimes.org is my email. Happy to provide it through Elodie or Heather, and then we can start to see if there's any question, and happy to take questions.
Dr. Gupta, thank you so much for such an informative presentation. We actually do have several questions that have come in, so I'll get started here with our first questions, and we'll try to get to all of them if that's at all possible. Dr. Sean Jones asks if the synthetic opioids without methadone line includes Suboxone.
They would not. So the Suboxone would not be part of the synthetic. There are a number of semi-synthetic and natural, but the methadone is pretty much the synthetic opioid category.
Okay. Dr. Wright asks, how much effort should be spent on the social determinants of health in addressing this epidemic?
I think very similar to the pandemic that we're seeing is just taking the covers off of what's going on. That's one of the reasons, amongst others, that we're doing so poorly compared to other nations of comparable standing. I think there should be a lot of attention paid. I think the pandemic, as well as this epidemic, and a lot of other aspects of public health or health, point to the same direction, which is, if you think about it this way, I tend to think about it this way. If there was some, and I've seen a lot of, someone that worked in the coal mine and, finds a way to put food on the table for their family, had a good systems, went to church, had community, and suddenly they lose job, which is the cornerstone of everything they stood for. It's like taking the carpet out of the living room, snatching it, everything falls apart. Not to offer that person the carpet back doesn't fix the living room. That's my analogy of saying that just treating someone with MAT or counseling isn't the only solution. It's about home, it's about community, it's about purpose in life, and it's about the health, of course. So I think it's very important for us to start to address and help address those factors. Physicians, traditionally and historically have been community leaders. And I think it's almost coming to time we need to get back to our roots of being the community leaders and helping community address those social determinants of health. So I would strongly encourage us to be able to play a larger role, any role we can, in addressing issues beyond our offices.
Thank you for that. That's great information, and it's certainly something we're looking at here in Kentucky. Our next question reads, there are media reports of a drop in heroin abuse that occurs when states legalize marijuana. Is this a true trend?
I think I wouldn't give a pass on the relationship, but I think the rise in synthetic opioids, which are easy to manufacture, ship, and distribute, it's almost a black market equivalent of Amazon. And that's what their intent is, really, to be able to have a way you can order and it'll be delivered to your door is a much larger threat. Although the jury is still out on legalizing marijuana, studying it for the health impacts or the damages it causes, perhaps. Those things are still out. But I do think that the drop or steadying of the heroin use is matching up very well with the rise in the synthetic opioid use, which is, you'll be surprised how sophisticated these operations are. Some of them, they come to the port on East and West Coast as a pro-drug, fentanyl as an example. Then they're shipped out to Canada, US, and Mexico. There are labs that will convert the pro-drug into the actual drug. And then they would be delivered on the highways, in cars, in nasal sprays, in form of pills that are very difficult to distinguish with real drugs. And they're going to every nook and cranny, every town you can imagine. So I think that type of mechanism, which is very, very sophisticated. The states have tried to legalize marijuana, but I think they're kind of falling behind in that sense because the mechanism of actual making money by the drug cartels is a lot more sophisticated.
I'm just reading through all of these questions. We have so many of them. I want to try and get to as many as we possibly can. There is a question that reads, is methadone use on the rise or is it rising due to prescriptions for addictions given at methadone clinics?
I would not say that there is absolute no diversion of drugs that are used to treat. But if you really start to look at why the diversion is happening, what we have found is not because of people want to get high on methadone, because there's certainly other areas. What happens oftentimes is there was somebody who's using, has addiction and using drugs, and now in the middle of night, they want to get treated. And they can't wait to get treated for another week or 2 weeks. And then they call in everywhere they want to call in. They can't get into a clinic for the next month, oftentimes, because we don't have enough clinics to provide that support. So what people are trying to do is buy methadone or other, even Suboxone, off the street so they can actually start to treat themselves. It's really in some ways, it's a shame. When we tell our European colleagues about this, they say, wow, we don't even know, we don't understand what you guys do, because in a lot of the countries in Europe, you can walk in to any place and get your medications if you want to be treated. We have artificial barriers in terms of ability to prescribe enough, ability to have it available when people want to be. It's like on our terms, and we have such a limited. So expansion MAT is very critical, but a lot of the evidence demonstrates that when methadone is diverted, it's because people want to get treated and they can't wait to get into a clinic or do not have the means to get into a clinic. That's the reason oftentimes for the diversion of methadone and Suboxone.
Thank you for that. Yesterday in some of our sessions, there was a lot of discussion about gabapentin, and one of our attendees wanted to kind of piggyback on those discussions from yesterday and asks about whether there's any data regarding the involvement of gabapentin in overdose deaths due to opioids.
That's evolving. We in West Virginia, we did a lot of the evaluations of gabapentin coexistence in deaths, overdose deaths. And what we found was, along with benzos, including gabapentin, we were seeing some trends. But one of the good news since then is we were having up to five or more substances found in the blood of decedents. People died from overdose. And that number went up to 5, and now it's started to go down to about 3 or so. So it's more of a cocktail And gabapentin can definitely be, and we have seen the evidence to show, is a part of the cocktail. But it's not just the only causative factor. It's part of that benzos, opioids, and gabapentin.
Okay. Our next question asks about just trying to recognize what are the better treatment facilities. Do you have some tips on how physicians can refer or know how to recognize a reliable, reputable facility?
Yeah, I think that's a very important question, because oftentimes what's happening is there are some for-profit folks there, and as is correctly pointed out, and there are those who are, and there's nothing wrong with for-profit, but there are those who are, sort of sell you the world. It's important to find those facilities around you, because travel and everything else matters too. And those who can accept insurance. Oftentimes, what we try to do is require facilities to accept insurance, because that's an important piece of it. So there are many good facilities within Kentucky. I'm happy to share some of that information that I've worked with. But I think the important piece is that I would stay away in referring to places that are going to exploit already an exploited population. And there are those who are working towards that. Often the good ones are associated either with hospitals or community-based facilities, often nonprofits also included in there.
Thank you for that. Do you have a list of resources that you would recommend, or a website that you would encourage people to go to just to get started?
The Safe Project US is one website. I would say there are a number of others. I will definitely could get you the list of those, but Safe Project US may be one. But I will share with you, Miranda, that we can get those.
That would be great. That would be great. I think we have time for one last question, and this one comes from Dr. Tran. And I will mention, Dr. Gupta, there are several more questions. If you're willing, we will send these to you and see if we can get some feedback from you, and we can share those with the audience at a later time. It's great to see so much engagement early morning, especially given our technical difficulties as we got started. So I'm really glad to see everyone participating. Dr. Tran asks, he says, thank you so much for the informative presentation. In addition to the sharp rise in fentanyl, we're also seeing in Kentucky a dramatic rise in the use of meth. Can you comment on the impact of the combination of fentanyl and methamphetamines?
Absolutely. Thank you, Dr. Tran, for that question. We used to see when people would either take a meth, which makes you hyper in so many ways. It is also related to crimes. Those are the people, it's not the people who are using opioids that you need to worry about from a criminal aspect of it so much. It's the ones that often go on a spree of both violence and crime and out of control, really are the ones that are on meth, if you think about it. And we used to have separation of these two. That's not happening anymore. You're right, that now we're seeing pills out there or drugs out there that have combo of both. Of course, the fentanyl, if even a little bit more than it should be, can kill people immediately. And I believe that's probably one of the driving factors to add meth to it. But we are seeing combinations now that we did not expect to see before, because those drugs just behave differently. Unfortunately, we went past that threshold. And now you're absolutely correct that the combination, you will not know how to address that right now, because there's no antidote for meth. If you think about it, there's no treatment for meth other than the standard principled way of helping someone with addiction. But for opioids, of course, there's MAT and other aspects. Fentanyl, of course, is one that can easily could kill you in a very, very small doses, because it's about 50 to 100 times more potent than morphine. So the combination of those makes it much more dangerous, unpredictable, as well as deadly. And unfortunately, we are seeing that. You're exactly right, Dr.
Well, thank you so much, Dr. Gupta. I'm not sure if you're able to see the chat, but we are just hearing from several of our attendees about how extraordinary and informative your presentation was this morning. We're so grateful that you could spend time with us today in sharing just this very important information. And I look forward to hearing some of the answers that you'll provide for us in future feedback as well. So someone just said 5 stars for Dr. Gupta. So wonderful presentation this morning. I thank you so much for being with us and for being patient for what we're learning is some sort of a national outage with the internet today, but everything worked well, I think. And the several hundred attendees that are online this morning, I think would share that as well. So in closing, I'll just mention to all of you virtually that our next session will begin at 10:15. There may be a couple of minute delays as we work to just ensure that there are no technical challenges or issues, but we hope that you'll continue joining us this morning. And Dr. Gupta, thank you again for being with us today.
Thank you very much, Miranda. Thank you, Dr. Wright. Thank you, Heather. And thank you all for listening to me. I appreciate it. Happy to provide any answers later on. Take care.
All right. Thank you so much, Dr. Gupta.